And so we're moving to Dr. Sharfstein, who will wrap us up. Hello, Josh, and share his thoughts and thinking about sort of the future in terms of policy and other areas that we could address and act on some of what we've heard from our prior panelists.
Great.
So
thank you so much, Dr. Smith. And can you see my slides?
Not yet.
Okay, no, good, because I have no slides.
Okay,
so if you were seeing slides, there was going to be a problem. So I just want to make
sure. That's a trick question, not funny. Okay, go ahead.
Okay. All right, sorry about that. Okay, well, as since you're my former chief resident, I'm allowed to do that once.
Yes,
I think.
Yes. You can.
It's great to be back at the Population Health Roundtable, and I wish we could be in person. This has been a really great set of presentations so far, and I'm just going to make a few comments. I want to start back with the great historical presentation that we heard that really described the tension that has existed for a long time in public health between a more narrow and a more expansive view of the job of public health. And I think that when the question is, what's the public health workforce and what are the key issues in the future for the public health workforce, we really do have to define what we mean by public health, whether it's inside the circle or bigger, and then what we mean by the workforce. And I think that what we've heard today is a pretty more expansive view of public health, that we're not just talking about discrete sanitary measures, and we're talking about fundamentally health and equity for the population, which is certainly a view that I and many people in public health share. In terms of the workforce, I want to suggest a distinction between the active public health workforce, using this broader conception, and a latent public health workforce. And what I mean by that is, active would be if you stop people in the street and you ask them what their job is, they would say they're working to improve the health of their community or a clear area, their county, their state. And latent, maybe they're doing work very relevant to that, but maybe they are not seeing it that way at the moment. So they are part of the workforce, but it is in some ways hidden even to them that they are. So with that framing, I wanted to divide the workforce into 4 parts. The first part would be the governmental, particularly the governmental public health organizations. That is all active. Most people at least should know that they're working for the health of the population. But there are major issues, and I thought the presentation from the Change Lab team was really superb in talking about so many different issues that affect in that workforce, including policy issues. I'll just pull out a couple of the things that they said. One is funding. We've seen tens of thousands of people leave those agencies. It's going to be very hard to succeed in this country in public health without a strong governmental public health workforce in that sense. So funding is going to be critical and is an issue right now in different budgets. It's, additional funding is contemplated by some legislation, but that's going to be obviously an enormously important factor to watch. But alongside funding will be the composition of the workforce. It's absolutely true that state and local health departments need more epidemiologists and data scientists, but there's really been a shift in and a broadening of thinking about having community health be part of the public health, the formal governmental public health workforce. As an example, in certain places that include Chicago and Baltimore, there were hundreds of community health workers brought into the COVID response. And many people are thinking quite enthusiastically about having a permanent community health, public health workforce that can address many different challenges in health in communities. I would also raise up the point that this public sector public health workforce really does need a protection in many places from harassment and mistreatment these days. And I think the Change Lab's point on that was actually very, very important. So there are other issues, but I'm going to move on to the second group, which I would call like the medical system, the healthcare system. Now, I think the healthcare system has both active and latent public health workforce. There are people walking around thinking, I'm in charge of population health, or I work on the health of my community for my health system or my community health center. That's part of my job in the healthcare system. But there are others who do stuff that's related, but don't realize it. There are some people, I might add, who think they do stuff related to the health of the community, but not quite. And For example, population health, despite the various definitions we've seen, is defined very differently by different people. There are many people in the healthcare world who define population health on an attributed population basis, maybe like just the people covered by a certain insurance company, or just the people who show up in a particular clinic, rather than a population in a geographic sense. So I think part of the challenge for this part of the public health workforce is to orient the healthcare system to the health of their communities through fundamental financial incentives around healthcare. I think it's very hard for people really to be oriented to the health of their community unless that is their mission and focus as a healthcare organization. Now, that comes naturally to community health centers, maybe not as naturally to other types of healthcare organizations. I also think it's very important to think about the training of people in these roles, because we want people to be able to look at true population health data, understand all the different tools of the field of public health, and not just one-on-one medical attention as a way to improve health in a community. All of the different policies that, for example, Change Lab referred to, as well as all the different community mobilization strategies that are possible to improve health. So a third group, besides the governmental public health and the medical system, would be other community-based organizations. And it was a terrific presentation, again, by Change Lab, talking about them. I think it's really important to consider these organizations part of the public health workforce, although I do think that only some of them really actively understand and are engaged in that, in part because of failures of public health to reach out to them. And so I think here the goal has to be to develop strong networks between governmental public health agencies and community-based organizations. We saw that in many places during COVID, that really brings people more from the latent to the active. These are groups that are working on the health of their population, although they may think, for example, their focus is on transportation or their focus is on housing reform, but bringing them into a public health coalition, working with them, that is a really important step. And I think also here, support can be very helpful for people in that workforce. Of different kinds, including opportunities to get trained in public health, opportunities to bring the tools of public health to their own organization. And I'll just say that this is one of the very fun parts of my job. I run the Bloomberg American Health Initiative. And in this role, we give out 60 full scholarships a year to people who are working on the front lines of health issues, key health issues in this country. And we're particularly looking for people who are in that latent public health work in other kinds of organizations. So we are giving full scholarships to people in school systems and planning agencies, in food nonprofits, in community safety related nonprofits. So we're trying to bring extra training and also help us understand, because we're getting trained in a way by people who have that sensibility, so that public health really moves in the direction of organizations on the front lines, and at the same time strengthens those organizations. And then finally, the fourth group I would say would be policymakers, because it's one thing to say there are a lot of policymakers who are doing public health related work, but not all of them really know that. Not all of them really understand the vast implications of their work for health. And I think here, a very important aspect of the role of public health is to provide tools to policymakers, health impact assessments, policy notes, others that help people see the impact of their work on public health, open their eyes, make them move from latent to active, and hopefully inspire them to align their work more with the actual health. In other words, they may be doing things that are very important for the health of their population, but not necessarily really considering that in their decision-making. Here again, I think reaching out with public health education and training is a really important opportunity for the public health field. So I see enormous importance to what's going on in Congress around funding, around the composition of the workforce, around protections for public health workers, but also these broader circles, the impact of healthcare delivery funding, the role of different kinds of assessments of different policies, and an enormous challenge for the education system, like our school and other schools of public health, to meet the needs of all of these different components, active and latent, within the public health workforce in the future to be successful. So Dr. Smith, I'll stop there and look forward to the discussion.
Thank you, Josh, for just a wonderful summary, and really appreciate the very compelling and systematic way that you went through the four areas, and for that distinction of latent versus active. I had started to think about, people who are working in adjacent sectors, but I like the idea of latent versus active. I think that that's even better. And just on that note, as an example of what you're talking about, many of the community-based organizations that the CDC Foundation has supported to do the COVID response work are groups that don't have health in the title. So they might be working on advocacy for migrant farm workers or agriculture workers, or they might be working to address or end homelessness in a particular area, or they might be doing civic engagement and mobilization for voting. So your point is well taken, that those groups are there and can definitely
and they can really be, it can be very exciting and mutually beneficial to engage with them about public health. About half of our Bloomberg fellows, the full scholarship, come from organizations that are not traditional public health kind of active partners. And it's really great to see like the light bulb go off, not just in our fellows, but in other people in their organizations, and just all kinds of opportunities for collaboration to happen.